Welcome you to our Lunch and Learn today, as we are going to talk about steady steps managing falls in dementia care. And we've actually invited two very special guest speakers, experts in falls and working with persons with dementia. I'll introduce them in just a second. I want to let you know that we are recording today's program, and we will have this uploaded to our YouTube channel in the next few days. But if you haven't visited our YouTube channel before, we have a plethora of our programs that we've done in the past that are up there for you to browse and for you to access at your convenience. And we also ask that you share with any family members or other colleagues that you're working with. These are all free resources that we offer. I will also send a follow-up email this afternoon. So the email will include information about how to obtain CE credits for today's program. So we're offering 1 CE credit for social workers, licensed professional counselors, nursing, and certificate of attendance. There will be an evaluation that we ask that you complete for you to get your CE credit. Of course, we ask everybody to complete the evaluation, as we do appreciate and use the feedback we get from you on our program evaluations. I will also include information about our upcoming programs that we have through the rest of February, and in March. We have some exciting programs coming up, as well as our support groups that we offer every week. Our next support group is going to meet at 1 o'clock today, actually. So if you're interested in that, we can get you the information if you want to join that online support group at 1. And Holly, am I missing anything before I go to introductions?
I don't think so. Just if everybody would please look at the calendar Jamie's going to send you. We have got some great stuff coming up in the next month and a half, in person and online.
Perfect. All right. So without further ado, so make sure we have plenty of time, and I know that they're going to have time at the end to answer questions as well, but please feel free to utilize chat while we have our presentation going, because we can refer back to any questions that you have in chat, of course, at the end, but we will have some time for you to ask questions. But our speakers today we have Barbara Hardy. Barbara Hardy is a registered nurse and a gerontological nurse practitioner, and she's the assistant professor in the Center for Geriatrics, the Institute of Healthy Aging at University of North Texas Health Science Center at Fort Worth. Barb Hardy is also a important fixture here at the James L. West Center. She's here constantly taking care of our residents, and we love having her, just obviously her expertise, but just as a person. And then we also have Rebecca Pratt. Rebecca Pratt is a certified occupational therapy assistant, and she's the director of our short-term rehabilitation services here at the James L. West Center. And I believe she's been with us for a long time, over 5 years, I believe.
Yeah, it's going on 6 years.
6 years. Okay, wonderful. And really taking our rehab and taking good care of our residents here that live here long term, but also come in short term. But she'll describe that a little bit more. But I'm going to hand this over to Barbara Hardy, and she's going to kick off the program today.
Welcome. So glad we have so many people from so many different states and Texas. I am a gerontological nurse practitioner. Some people say geriatric nurse practitioner, which just means I'm old, and you can see the gray hair. But I've been here at actually James L. West for like 26 years. So been here quite a while, and I do see all the residents here. So my expertise is really in dementia. So we're talking about dementia and falls. So I thought what we do is basically look at what's going on in the brain and why we can expect falls with dementia. So basically, when we talk about dementia, we're talking about all the different types. You know, we have many different types. Dementia, the Alzheimer's type, which are the plaques and tangles in the brain. We see those on autopsy, also through PET scans. And then we have dementia, the vascular type, which are the small strokes that occur throughout the brain. We do know the brain does not usually age very well. So on autopsy, we can see quite a few of those. And then Lewy body, which is, you know, the abnormal proteins in the front, which affect executive functioning, and traumatic brain injuries. There's a lot of different types. One of the first things we do, of course, when we're trying to diagnose if a person actually has what type of cognitive loss, is, you know, we draw a lab, we look to see, is it an anemia, is it a thyroid problem, kind of what's going on. And then we do a lot of neuropsych testing to really get a clear picture of what part of the brain's affected. So we know what we're looking at, basically. By the time someone comes to like James L. West, they have been diagnosed, and we know we have some type of dementia going on. So then our job is to kind of figure out how to keep them in the safest environment we can. And we do know it right now, it is a progressive terminal disease. We have nothing to stop it. There's a lot of research going on. I'm also what's called a clinical research coordinator. So what I do at the university for the Alzheimer's studies, for the new drugs like bapineuzumab, crenezumab, I've done vitamin D, vitamin E, estrogen, in charge of the FDA trials to get a new drug approved. So been through a lot of trials. We've not found anything that will actually prevent it. We have found medications, the IV, some of the IV medications that can slow it. So again, lots and lots of research going on in every country in the world. This disease is not just in the United States, it's throughout the world. So researchers at the international conferences are all sharing their research and what they've done. So hopefully we're going to crack it, but it's just taking a while. So what is happening in the brain? So someone diagnosed with any of the dementias, what we're looking at is cellular death. Okay, so we'll concentrate on Alzheimer's. So with that, it starts out slow, mild, and we can stage it through the different stages. So in the beginning, there's just a few of these abnormal amyloid plaques or tangles within the brain. Person's doing fairly well, they're managing, but they may be losing words, they're getting forgetful, they're repeating themselves. They may get lost on the way home to their house they've been in for several years. So we're looking at them having a lot of, starting to have a lot of problems that the family's actually starting to notice. This disease has probably been around a long time. We used to say, grandma was senile, so it's been around a long time. The brain just doesn't seem to age very well. There are things we can do, staying healthy, keeping your weight down, eating healthy, exercise, keep the brain flowing, the blood flowing through the brain. All those are good. Keeping the mind active, learning another language, puzzles, all those are very good things to do. So as this disease progresses and as more of these abnormal plaques and tangles form, as this nerve cell, which is called a neuron, tries to communicate with this nerve cell, there's a plaque that's in the way. So the communication can't get through. And again, in the early stages, there's just a few. I've had people say, why can't we just scoop them out like we would with a tumor? And it's a legitimate question. The problem is they're all over the brain and they're at a very small level. So it's not like a tumor you can just see and scoop out. So that's why the medications target pulling that amyloid away and destroying it. So that's what we're trying to do. So as more and more of these amyloid plaques and tangles occur in the brain, what happens is more and more of these disruptions can't get through. Okay, so you're having more and more problems with memory, with thought processes, with what we call executive function, which is how you plan and organize your day, how to drive a car, how to fix something to eat, all these different ways that you organize your day. So what we're looking at as more and more of these plaques and tangles occur in the brain, we're looking at safety issues. And this is where the falls come in. As the brain deteriorates, you have less safety awareness, okay? So where you and I might see a chair in the way as we're walking, they may not recognize that chair as a chair. And you see this where they don't recognize a family member's face. They just don't recognize objects for what they are. So they're going to run into it, okay? So that's where we have the problem with falls. They also get more unsteady on their feet, okay? So what happens is they get weaker. The other thing is, depending on where the majority of these plaques and tangles are, they may forget how to walk. Okay, so then, and there's also something called fear of falling. Once they start falling, they may quit walking. So our goal, of course, is to keep people walking as long as we can, as active as we can, but that may not always be possible. And I've talked to a lot of families about that are very insistent that their loved one keep walking. And I understand that. That shows that they're still independent. They can still get somewhere. They need less care. But sometimes it's just not going to happen. On the flip side of that, you have the people that are determined to keep walking. Okay, even if they're very weak, they're going to get up, they're very impulsive. So again, you lose that safety awareness. What we're also looking at are sensory impairments. Okay, they were already hard of hearing, they may not hear what's going on around them, so they're not aware of their environment. And eye issues, again, it may not be like, it could be glaucoma, something like that, but also what they're seeing may not be exactly what's in front of them. So we have to really look at what else is going on with them. A lot of them quit eating, so now we have malnutrition on top of that. So we're trying to figure out, how to keep them as healthy as we can with supplements, whatever. One of the first things I do is a dental exam, what's going on in their mouth. They sometimes can't tell you. So do we have a problem, especially with a stroke? They're not swallowing well. It could be the teeth. Is there a bad tooth in there? So we have to look at a huge picture. You're not just looking at one thing here. The other thing that we look at, they don't just come to us here with just dementia. A lot of them have heart failure, arthritis, all these other things going on. So one of the first things are they in pain? I'm very much trying to be sure they're not in pain. They can't always tell us if they're in pain. And if you're in pain, that's what you're concentrating on and not exactly what's going on around you. So I'm always looking at pain issues. I put a lot of people just on Tylenol, 650 milligrams twice a day. They probably have arthritis. A lot of them that can't get up are sitting. They've got the low back pain, compression fractures, could be any number of things. A lot of them have fallen and have had fractured hips. So I'm very much into checking, are they in pain and how do we control that pain? And again, this is a balance because you don't want to give them so much that they're going to fall. But also if they're in a lot of pain, that also increases their risk of falling. So we are constantly looking at what do they need to keep them walking? Are they in pain? The other thing I do a lot of is I look at medications, of course. What are they on? We get some people that come, and I'm sure other facilities, I go through every medication. And what I do is I ask the family, is there a reason they're on this medication? And sometimes the family doesn't know. Well, they've been on it for years, or I'm not sure why, so maybe it's a good time to take a trial of slowly decreasing that medication, especially if it might be something that might contribute to falls. So a good medication review is very, very important. Sometimes you say, well, they're very anxious. That's why they're on this medication. So again, if they're so anxious, that increases the risk of falls, but some of the medication can also increase the risk of falls. So our job is to try to balance out what medications do they need, what will work best for them to keep them up, moving around, arthritis, all these other things we have to look at. So again, basically what we're looking at is a whole lot of different factors. And as the disease progresses, like we talked a little bit about the stages, as the disease progresses, they're probably going to get weaker. They're going to get more forgetful. They're not really their gait's going to get unsteady, especially if they have Parkinson's, something like that on top of the dementia. So that's where the therapy comes in to try to keep them as active as we can, try to keep the environment as safe as we can, moving obstacles they could run into, sharp corners, trying to reduce the risk of falls. So that's kind of an overall picture. The main thing I'd leave you with is, the brain is changing. Unfortunately, we're losing brain cells that help us to be safe for ourselves. One quick thing is like when to take away the car keys. We could spend hours on that. They're not safe driving. They do not realize they're not safe. And, we never ever argue with someone with dementia. You're not going to win. So basically, change the subject, redirection, whatever. But saying you can't get up, mom, you can't keep trying to walk, you're going to fall is not going to work. So basically just trying to keep the environment safe, checking the lab, keeping the right amount of medications, and, just a lot of support overall. Okay. So we were gonna leave it open for questions at the end. We'll just do that.
Yeah, we'll leave it.
Okay, we'll leave it open for questions at the end. I'm gonna let Becca do her deal and then we'll be here for any questions.
All right, my name is Becky and I'm the director of the rehab department here at James L. West. I've been here for going on 6 years now, and now we are doing rehab with our long-term care residents, and we're also doing short-term rehab now. And on both sides of it, one thing that we definitely always do see a lot of is falls. It just happens in the natural progression of the disease. So that's one thing that we work hard to manage. And I am going to share my screen with you so that those of you that are visual learners, you'll have a good idea of, you can take notes a little better on what we're doing here. Oops. Okay. So with dementia, the number one thing we can do to address falls is prevention. We need to prevent those falls before they happen. So how much does having a dementia diagnosis increase your risk for falls? I found some interesting information published in the Alzheimer's and Dementia, which is a journal for the Alzheimer's Association. And it's that nearly half of older adults with dementia experience falls. It was 45.5% of those with dementia experience one or more falls, compared to only 30.9% of their peers without dementia. So you can see there that there is definitely an increase in the number of falls with the people after they have the dementia diagnosis. And it's for a lot of those reasons that Barb had talked about. So let's talk now about how dementia can affect a person's balance. It's in several ways it does affect the balance. First of all, it's the brain damage. Dementia causes damage to various parts of the brain, including areas responsible for coordination and movement. And this can directly impact the person's ability to maintain their balance. Spatial awareness. People with dementia often have difficulty judging distances and navigating their environment, which can lead to them bumping into objects or misjudging steps. Something might look further away from where they're judging it is from what they're seeing, or they might not see a step. So they have to just be very careful there. Slower processing. Dementia can oftentimes slow down a person's ability to process information, making it harder to react quickly to changes in balance or position. Somebody like you or I, we might be walking in, we kind of stumble over something and we're able to process that and correct and maintain our balance again. Whereas somebody with dementia, because of the slower processing, they might stumble over a crack, and before they can process what's happening, they're already on the ground. Gait changes. And as the dementia progresses, people develop an unsteady or shuffling gait, which is oftentimes a risk for falling and tripping. Muscle weakness. People with dementia oftentimes have reduced physical activity due to their cognitive decline, and that can lead to muscle weakness, which then further compromises balance. And another thing that Barb just talked about is the medication side effects. Some medications used to treat dementia symptoms can also oftentimes cause dizziness or affect the balance. So that's something that you really have to work with your provider on, is making sure you have the right mix of medications that aren't affecting balance and putting you at further risk for falls. And also the visual perception. Dementia can affect how the brain interprets visual information, making it harder to navigate around a room safely. Sometimes you'll notice people with dementia, they can be walking, they don't notice something right in front of them because their visual perception is off on that. And also cognitive overload. Simple tasks like walking may require more cognitive effort for somebody with dementia. And because it takes so much cognitive effort to put one foot in front of the other, they have fewer mental resources for actually working on maintaining their balance. So, those are all different ways that dementia can affect balance. So it's important to notice in dementia that the balance problems can occur at any stages of dementia. Sometimes it even appears in the early stages before there's major symptoms that are apparent. And unfortunately, these issues do tend to worsen as the disease progresses, which increases the risk for falls and injuries. That's why we always need to, keep monitoring different changes and abilities with walking and balance and things of that nature. One thing, as the dementia progresses, it's important that we always provide supervision and assistance with daily activities. Regular supervision and assistance with daily activities can help manage and reduce risk for falls. And this includes supporting with mobility and ensuring safety during tasks such as getting out of a chair or a bathroom. You and I might look at it as something that we do in our everyday tasks and not as a challenge, but with somebody with dementia, it can be a challenge. So we need to make sure that we're providing regular supervision and attendance assistance that they may need. One thing that we can always look at is home safety modifications and environmental hazards. Creating a safer environment is key to reducing risk for falls. And here are some effective measures we can take. First, remove throw rugs and secure loose carpeting. These can be major tripping hazards, especially if you're using a walker or maybe you're not picking up your feet as far as you had to. It's so easy to get caught up on that rug that's on the ground. So sometimes if you don't want to totally remove your rugs, sometimes you just have to tape them to the ground so that they can't get caught up on them. Remove any tripping hazards. You want to remove clear clutter, secure loose rugs, remove unnecessary furniture to create clear pathways throughout the home. You might have in your home, you might have the little cutesy end tables or something that is more of a decorative thing. But at that point, they're really not, if it's not a necessary piece of furniture, it can just get in the way and provide distraction. You want to install handrails on both sides of staircases. That provides more support and stability when trying to get up and down stairs. Or maybe even move living quarters down to the first floor so that they don't have to manage up and down those stairs. You want to improve lighting throughout the home, ensuring that all hallways, all areas, especially long dark hallways or bathrooms, are well lit. That will help prevent against falls as well. And it also helps to use contrasting colors, which can help with depth perception. For example, use a different color for a toilet seat than the floor, because in a white bathroom, a white toilet seat, somebody with dementia may have a trouble seeing the the difference in where exactly the toilet is there. And if you're just pointing to it saying, "Oh, the toilet's right there," they may say, "Oh, my caregiver just told me the toilet's right there," and they may go to sit and they're not actually in the right area to actually sit on the toilet. So sometimes having different colors can really help with that. And you also want to clear clutter and create wide pathways. That allows for easier navigation, especially if you're using a walker or a wheelchair. Narrow passageways can be very hard to get into. You might be running into things. If there's, like we talked about the cute end tables, those might get in the way too. So just clear the pathways so that they can easily get through. And you always want to look at nighttime safety too. You or I, we probably get up to go to the bathroom throughout the night, no problem. It's a task that we do many times and no problem. But with somebody with dementia, navigating in the dark can be much more of a challenge. So you want to use night sensor lights to illuminate clear pathways to the bathroom. The motion sensor lights are really good because it might be hard just to, trying to get up and find the light switch. So the motion sensor lights will really help with that. And you also want to install safety equipment where possible. Put grab bars in bathrooms and handrail and bathrooms and hallways. Like we talked about, handrails on both sides of the staircases. Wherever possible, you think a grab bar might be handy would be a very, very great thing to help prevent falls. And non-slip mats in showers and bathtubs. That will help also for preventing falls in the shower. You might want to also, as the disease progresses, you might want to also look at using shower seats, tub benches to make it easier to manage being in the tub, taking a shower when you're handling those things. And you also want to organize frequently used items. You want to keep everyday items within easy reach to prevent unnecessary stretching or bending. For example, in the bedroom, instead of having, the jeans that you wear every day on the bottom drawers where you have to bend over and reach down, maybe you want to put them in the top drawers, or maybe you even want to make it a little bit easier and maybe put all the clothes that you wear frequently right on top of the dresser, so they're easily found. In the kitchen, you probably want to have your glasses on the bottom shelves in the cupboards so that they can be easily reached instead of having to reach up on the top shelves where you're at risk for being off balance and falling. Another factor for managing falls is to look at the importance of footwear, proper footwear, and mobility aids. Proper footwear can make a huge difference in preventing falls. You always want to look for shoes that have non-slip soles. Bare feet and then regular socks can be very, very dangerous. They can slide easily on floors and put you at risk for falls. So maybe they'll also have the person is not willing to wear shoes. In that case, you can always find non-skid socks with the little grippy feet on the bottom. And you also want to make sure that the shoes fit well and provide good support. If the shoe isn't fitting well, it might be sloppy. You may be at risk for, turning your ankle and slipping and falling. So make sure it's a well-fitting shoe. Make sure that the shoes are easy to put on and take off. Lots of times if it's too hard, the person with dementia might just refuse to put on their shoes if they're too hard to take on or off. So make sure they're well-fitting, they're easy to take on and off. And you want to make sure that the shoes have low heels and a wide base. That will give you a more supportive base to stand on. And you always want to avoid backless shoes, high heels, or shoes with slippery soles, because that's just an accident waiting to happen. You want to stick to that, like I just talked about, the well-fitting shoe. Okay, and then so if after you have good shoes on your feet, you want to make sure that maybe you're using proper mobility aids as needed. And that's where training with physical therapy can really help. They can recommend proper canes and walkers and ensure that they're fitting properly and used correctly, which can be a huge help. However, when using walkers, you might want to address that in the early stages of dementia, where the person with dementia is more able to learn how to use a walker, how to use a cane, and they're more apt to using it correctly and remembering how to use it. That's oftentimes a problem that we see with dementia is you can train somebody how to use a walker. They do great with it, but only when you remind them to do it. So sometimes you might need to take a walker and decorate it so that they know that it's theirs, something that they want to have with them, they want to use. Maybe you need to use, pretty colored ribbons and bows to remember to use it. Or maybe you need to put a picture of a loved one right on the walker so that they remember to always have that with them. Those are some good ideas for training and using a walker. Now let's talk a little bit about exercise programs. Regular exercise is crucial in maintaining strength, balance, and flexibility, which are all essential for fall prevention. Let me take a little drink here. And it's always good to start using the therapy interventions before the fall. You might notice with your loved one or somebody that you're caring for with dementia that their balance is starting to be a little bit more compromised. They're starting to trip a little bit more. They're starting to maintain maybe furniture surfing or leaning on walls a lot more. And at that point, that's when you actually want to start the physical therapy, because if you wait till after the fall, at that point you might have an injury, or it will just be the person may have a lot more fears of falling. So you want to start intervening early with therapy interventions. So you want to engage in strength training and balance therapy, because that will improve your overall stability and reduce falls. Activities such as squatting or standing up from a chair and walking may be difficult and cause many people to feel unsteady, which increases the risk for falling. So that's why somebody with dementia, you want to practice balance training and strength training early, and you want to do it with a professional to provide safety. And also repeatedly doing it with a professional will help give the resident or your loved one more confidence in doing it. If they're doing it with somebody who helps guide them through the process of sit to stand or walking straight down the hall, that will really help just build the confidence and feel more comfortable doing it on their own. And physical and occupational therapists can provide targeted exercises and interventions to enhance the muscle strength and coordination. And research shows that it's important that you use individual exercise programs tailored to meet specific needs and abilities of people with dementia. That's one thing that we really focus on here is the residents that we have for rehab, we don't have a cookie cutter approach for treating falls and dementia. You have to look at the cognitive challenge each person faces. You need to each person faces and incorporate their program to what exactly their needs are. Because everybody's challenges are going to be different. They're going to have different physical limitations. So we really need to look at and develop individualized programs. And another important thing we can do is incorporate caregiver involvement to ensure a supportive environment and further enhance the benefits of the exercises we're doing. You know, the person that we're caring for, they might be in therapy just for, 30 to 60 minutes, maybe 2 to 3 times a week, 2, 3, 4, 5 times a week. And sometimes that doesn't provide a lot of carryover. So if we can get caregiver involvement, then maybe they can do the exercises, repeat the exercises several times throughout the day so that we can have enhanced carryover and the, stronger chance that the resident will maintain and adhere to these things that we're recommending. All right. And there's also different ways we can adapt the home or the environment to better accommodate the resident with dementia as dementia progresses. It's always good to use visual cues. You want to incorporate visual aids to help with navigation with daily activities. Sometimes it's good to place large or clear photos on doors to indicate rooms. If a person is spending a lot of time wandering, trying to find the bathroom, and they get tired, they get to start to be off balance, maybe you need to just put maybe a picture of a toilet right on the bathroom so that they know right where to go. Or maybe on the bedroom, put a picture of the bed right on the doorway so that they know where to go for that. So they're not wearing themselves out wandering looking for it. You want to use contrasting colors for important objects like toilet seats, handrails, and light switches. That will help make it easier for somebody with dementia to find these items, which can help with safety. And sometimes you might want to even use pictorial labels on drawers and cabinets showing what's in the contents. If somebody's spending a lot of time rummaging, getting anxious, trying to find something, starting to throw their balance off because they're getting fatigued, maybe put picture of the jeans right on the drawers, or put a picture of glasses right on the cabinet doors, or maybe even take cabinet doors right off so that they know right where to go and they can make a clear pathway of getting there. Okay. And you also want to simplify and declutter. This helps reduce visual confusion. You want to remove unnecessary furniture and decor to have clear pathways. Sometimes you might have, the cutesy rugs. Go ahead and take those off because that can be, a trip hazard and unclear. You might have clear vases around or certain decorations, but you're going to want to just remove those because they can be a trip hazard. Okay, using solid colored bedding and window treatments instead of busy patterns, because this can help with eliminate distraction and show a person can better visualize just right where they need to go. And you want to store rarely used items out of sight to minimize choices and distractions. If there's too many distractions and somebody's walking down the hallway, they might see, all the busy patterns and items that might interest them, and then they get distracted. They start going one way and then they start going another way. So you want to really minimize those distractions because that is a fall risk. And also maybe glass items that you might have, like picture frames or vases or decorative plates. You might want to just put those away because if there is a fall, that clutter, they could get wound up in the fall, and then you could end up with broken pieces that could cut the skin, and that's something that you really, really want to be careful of. Okay. And another thing we can do to really help those with dementia and reduce risk for falls is create safe wandering paths. Some people with dementia are just prone to wandering, and that's kind of how they find comfort, is wandering throughout the day. And you can't really compromise with them and say, you keep telling them to sit down, sit down, because the more you tell them to sit down, the more they're going to want to stand and wander. That's exactly what they're going to do. So if somebody's going to be wandering, you might want to install motion sensor lights along hallways and bathroom. That's one thing we've already talked about. use contrasting colors to create a visual path throughout the home. Maybe you want to put, you could even put like brightly colored tape right along the hallways to create, show them where they need to go if they're going to be wandering. You might want to place familiar objects as landmarks around common routes. Like we talked about, maybe familiar objects, put signs on the doors of the room so they know where to go. If you have a long hallway, or if you have an area where somebody wanders a lot, you might want to put a chair down in the middle of the hallway, so if they start to get tired, they can sit down. And if somebody is wandering a lot throughout the day, pacing, you might want to look at just creating a safe circular path around a central area where they can pace that area, objects that they might trip over or get distracted by or removed, because that will give them a sense of security, a place where they can wander and they don't have to worry about getting hurt. So that can be very helpful as well. All right. And those are all ways that we can help reduce risk for falls. Does anybody have any questions? I will not share my screen anymore so that we can answer questions. Both Barb and I are still right here.
And feel free to unmute yourself, or you can put it in chat if you have any questions. There were some suggestions in chat as y'all were talking. There was the Walker Squawker cardinal that sings. So you were talking about adding stuff to the walker cane so they would use it. And they wrote that down. I've not heard of that yet. But then people that love clutter or like to have that clutter around them, what do we do for that? And there was some great stuff put in chat. But you know, having a rummage box or a rummage closet or even a rummage room to where they can go and they have their stuff, but it is put in, you know, it's not spill over everywhere into the house and lessens the risk for falls. But are there any other questions or comments? Again, feel free to use chat or unmute yourself.
Take advantage of having these two experts here. I see some people typing. I know we've got some stuff popping up.
I have some questions that no one has, but
Aha, there's one.
so what kind of impact will a UTI on a dementia patient have on the patient's mental status?
Okay, well, and Becky can comment too. Usually, you know, any type of anything that causes pain, and we treat a lot of UTIs. You know, they don't clean well, or they retain urine. A lot of don't drink enough fluids. A lot of reasons for UTIs, and it just can cause confusion. And you know, it is a bacterial infection, so you know, it needs to be treated. So it can just make a person more restless. They hurt. They don't know why they hurt. They maybe having to urinate a lot, and when they urinate, it hurts. So again, if we start to see signs of a urinary tract infection, the first thing we do is try to get a sample, because we want to get the right antibiotic. So that's where the culture and sensitivity comes in to treat it. And I know some people have chronic urinary tract infections, but we're very quick to recognize, and I listen to families. If they say this is how she always acts when she gets an infection, and men too, then, you know, we're quick to try to get a sample and to treat it. And, you know, encourage more fluids too. That really helps. But a lot of these people don't recognize thirst like we would, so they don't drink enough lot. So we have water rounds. We have them bring water carts around and really encourage people.
Yeah. And you have to be careful with that too, because when somebody does have a UTI, they might have increased frequency, more urge, and they're trying to get to the bathroom as fast as they can, and that can really put them at risk for falls. So that's another thing that you have to be careful of. All right, what other questions do we have?
So this goes back, so this chatted in, my husband has thousands and thousands of books in large shelves in different rooms that he may, he has many rifle cabinets packaged with tapes and DVDs and furniture, and he gets upset or angry if I touch it or, you know, try to move it, no matter what I do. Do y'all have any suggestions for managing that situation?
You know, I would say if they're on cabinets and shelves, that's a much safer. Maybe put them more to a part of the room where he's not wandering so much. I mean, maybe put it just where he can still see it, because he needs to know that it's there. Put it so that he can just see it, but maybe that so it's not in a path that he wanders a lot. Because it might make him very anxious if you were to just take it away.
And there was, oh, someone said that my husband doesn't even look down as he walks, which is funny because I always look down when I'm walking. Yeah, so that's something to look for. And I appreciate y'all mentioned what to look for as somebody might have increased risk for falls. So they're not looking down, they're stumbling over stuff, they're leaning on furniture. So those are some warning signs that if we don't put these prevention stuff or safety measures in place, now's the time, because they're starting to show us they're at a much increased chance of falls. So how can we help a loved one who shuffles instead of walking?
That's again where a physical therapy referral is good, because maybe they're not picking their feet up far enough. Maybe they're not putting one foot in front of the other enough. So that's where a physical therapist can assess, determine what gait abnormalities are, and do some teaching and education there.
And keep in mind also that throughout the course of the disease, that they are going to go in and out of PT, OT, ST. All of the therapies are so beneficial. And in the case of dementia, we're not curing anything because we can't cure it. But the therapies are helping maintain quality of life. And therapists who are trained in memory care, they know how to tap into that muscle memory. And so many times the muscle memory is what remains. So that's where you go to your physician, you ask for that referral to physical therapy, occupational therapy, speech therapy, whatever it is that they're needing. And you will see throughout the course of the disease, they'll go in and out of the therapies repeatedly. So like Becky was saying, it is always worth asking for the referral and then making sure that you get therapists who know how to work with people with dementia. That's a key also.
And I will say a key, what Becky had said, is that you as the caregiver or care partner need to learn those exercises and those strategies so you can start doing them at home, reinforcing them. It's not you just take them to the doctor and leave. You need to learn those exercises too, so you can continue to reinforce them, as she mentioned. I know, oh, so I know this isn't on the subject, but you said in and out of therapy. Is this because the disease goes in and out? One day my mom seems normal, or will be for a week, and then a week of decline, and then back to.
And it's not that the disease is coming and going at all. I'm talking about the progression of the disease. The reason that they can seem, quote, normal is because, like Barb was talking about, when the disease is, especially at the beginning, as it's progressing, there's going to be times that they're connect. I ate well, it's sunny outside, you're in a good mood, there's some music playing, I slept well, connect. But then it's a gloomy day, you're in a bad mood, I'm in a bad mood, I didn't eat, I didn't miss. And it's like they're a completely different person.
I've had family members, I sometimes argue they don't really have it, because they have, just like Holly's saying, they have several good days. Or the long lost brother comes in and spends an hour with mom and says she's fine to the sister who lives with mom. And, I'm saying, make him spend a day and a night with her. So yeah, it's some connections get through, especially in the beginning, and some don't. So again, that's why the neuropsych testing is so important, because these tests look at all different areas of the brain. It can pinpoint different things where the most issues are going to be. So anyway, it's a difficult disease. It's not something you can just say, we're going to do this and fix it. It's constantly changing.
Mm-hmm. Once you get used to one way to manage something, there will be a change. You need to pivot again and find new ways to manage and cope.
Thus, support groups for you, for the caregivers.
Yes.
We've got a couple more questions. Does meditation help early dementia patients to improve mental function and retard mental deterioration?
I'd say meditation is good for everybody. you know, because they can maybe focus, and especially if you can get them to focus on what they can do and not what they can't do. And family members need to do that too, emphasize what they still can do. Yeah, so I think meditation, if, you know, you can get someone to do it. The issue is going to sometimes be the attention span, because when you meditate, you really got to clear your mind, and, you know, and a lot of these people you're going to find, even in the early stages, they're kind of a little bit all over the place. And so their attention span isn't real good, but I think it's excellent if they can do it.
And it might also bring a sense of calm when there's so much anxiety and they're having a lot of problems with anxiety and getting restless, and could bring a sense of calm and help with that as well.
And I think if it was something that was already part of their past, if it was already a skill that they had, a coping technique that they used, most definitely. Introducing it as something new, why not try it? You might try it. Another question that came up is, how do I deal with sudden anger spells? How do I react? And I'm going to speak to that, and then I'm going to turn it over to Barb and Becky real quick. First of all, let's replace that word react with respond, because we don't want to react. If we react, then we're going to go in with just that, a reaction. We want to respond. So they have that sudden anger, something has triggered, something has kind of pushed them over. First thing we need to do, we've got to take that breath, because we have the 3-pound brain. We have the brain that can make the decisions and respond rather than react. We're going to validate their feeling. We're going to fix whatever's going on, even if it's with a therapeutic story. And yes, that is a lie. And then we're going to distract. Those are the 3 things we tend to say. Let's validate what's happening, because it's very real to them. Even if it isn't real, it's very real to them. You took all my money. Oh my gosh, let's call the bank and get my name off of that account. That's terrible. Is it a story? Yes, it's a therapeutic story. We're going to their world. And I've got some ice cream over here. Let's go get some. Glad I got that taken care of. Validate, fix, distract. Something else that you could add, Barb and Becky, as far as sudden anger spells.
I think you're hitting it pretty good. I mean, you know, it's going to happen. And again, be sure you're safe, number one, because I've seen people lash out that have been very calm, gentle people sometimes. But basically, it's, you know, be sure they're in a safe environment. Don't argue. Don't try to reason, just like Holly said. It's just going to make them more frustrated. So get their mind on something else. Let's go for a walk. Let's have some ice cream. And, oh, I'm so sorry about that. I love the color shirt you have on.
Yeah.
Because their mind's like a light switch sometimes. If you can hit that right switch, you're gonna be okay.
And sometimes you just have to let them have that angry moment, and they'll get over it, you know. Let them have that moment for, you know, make sure you're in a safe environment, they're in a safe place, and, you know, let them have that moment.
And with the anger outburst, it could also do with pain, potentially, especially if they're in therapy, right? But Barb talked about pain and checking for pain, because it could, if we don't see like a wound or something, and they're not able to verbally say, hey, I've got my shoulder's really acting up, and then we're trying to do some range of motion. It could be something like that too.
And if we ask somebody with dementia, are you in pain? What are they likely going to say? I see lots of people on here that know the answer. That would say, no, while they're holding that shoulder. So
Yeah, you
Yeah.
definitely need to learn to read the signs.
yes, no is one of the first 5 words that we learned. No is one of the last words that remains. But they will tell you with their body language, their face, furrowed brow, their tone. So we just have to learn to read their body also.
I want to say something as a caregiver, because I realize that sometimes when there's a change in the mood in the individual that I'm taking care of, that I have to really take care of myself and not overreact to that change in that loved one. And it's like, oh my God, what else is going to happen now? That we need support as caregivers so that we don't overreact and don't respond to them, to their needs, but we're caught up in our own feelings. And I think it really pays to be part of a support group or to have some friends who may also be caregivers so that we have a sense of preparing ourselves, but also responding appropriately. I wish that years ago I had heard Becky talk like this, really about preparation as a caregiver. And I'm very grateful for this presentation. I hope that we will have more of those because I think what Barbara and Becky talk about are very real issues. Even like the whole idea of the lights at night, which were for a long time with my mom such an issue. And it's easy to get caught up in that, like, oh, I'm not doing it right. I'm going to have to get something else. I don't know if any of the rest of you respond to that, but I've certainly been in that position. And it takes some work on the self, to be able to do self-care and care for the one that we love.
Thanks,
Good.
Judy.
Very good.
One of the things, Monica had put something in the chat, which I wrote back to her, that said that a home health doctor came to evaluate her husband. She said he did not qualify because he was able to go up to the door, up the stairs, and push against her hands. I told her, of course, that she was seeing this short window of time and that it varied throughout the day and that she was educating herself because she's in many of our classes and on the support group. And the physician actually told her that they had a doctorate and that what they were asking was like going to the eye doctor and after the prescription was given, asking it to be changed. And I told her she needed a new doctor. That was what I said myself. Barb, how do you feel about that whenever you got somebody that says something like that?
Oh, well, we see that. That's why, we have a memory clinic, people come in, but no, you're going to get, if you're with a primary care provider, diagnosing this disease takes a lot of time. There could be so many other things going on. It's a disease of exclusion. We're trying to rule out so many other things. But you, as you know your loved one and they're not acting right, and we've ruled out all this other stuff, but it's very time consuming. That's why, geriatricians, and we have a huge shortage of geriatricians, but trying to get to the right person. I first off would insist on a neuropsych evaluation, and there's neuropsychologists out there. It's usually about 4 hours. It is difficult, but you need the diagnosis, not just for yourselves, but I've had to have it done for insurance reasons. It has to be documented that they've been assessed. So to spend 5 minutes is, like I said, when the brother comes in and spends an hour, something's wrong. So again, I think she was smart. I would go to a different physician. And if someone talked to me like that, I have a bit of a temper. I think I would have said, get out of my house, whatever. But, just use your own good common sense, your loved one, and find another provider.
And Barb, the question here, if does Medicare pay for neuropsych eval?
I don't know. I think if you're referred to them, it depends probably on how the wording is and what diagnosis you do, cognitive impairment. I'm really not sure because we have it in our clinic, but I'm always out in long-term care. But I would ask your provider. I think I would think it would be paid for, but I can't guarantee it.
Oh, go ahead. I was gonna say, Adris has her hand up if you want to
Yes,
unmute
go ahead.
yourself.
Hello, good afternoon. Oh, well, good afternoon. I'm a social worker, and yes, it is covered through Medicare. Also, I just want to tell people too that remember the doctor is working for you. So you can always advocate for yourself and your family members.
Yes, thank you. There's a social worker talking right there. Thank you. What suggestions do you have to encourage your loved one to eat? Good question.
Well, Becky and I can both
Yeah.
talk with that. Becky probably more with, well, both
Yeah.
of us with food that they like, smaller
Yeah.
portions, don't you
Yeah,
think?
yes, smaller portions. A huge plateful can be so overwhelming. And at this stage of the disease, lots of times we're so worried about eating healthy, getting the right thing in. But at this point, you want to get anything in. So maybe give them their favorite thing, even if they want a bowl of ice cream for every meal, you know?
Mhm.
It's, you just want to get food in there.
Yeah, yeah.
And watch what kind of maybe textures, maybe certain textures they don't like, or just consistencies. So try and find, you know, those types of foods that they accept the most.
Yeah, we don't really worry about, even with diabetic patients, once they get to a facility, we don't do diabetic diets. We may give them a smaller piece of cake, but if everyone's having a piece of birthday cake, we're not going to deny them. And if we have a lot of people that actually gain weight when they come to a facility because they're eating with a group, they're with other people, you know, and it's more social. And so again, I think you just have to find out what they like, encourage them to eat. Don't push vegetables or something else if they don't want them, and just try to get as many calories in them as you can, because eventually they're going to stop eating. I guarantee you, they're going to stop eating. They're going to start dropping weight, and no matter what I do, where I go, we don't allow feeding tubes, because the philosophy is a natural progression of the disease is they're not going to eat. You force food into a body that's shutting down, severe constipation, they get uncomfortable. We've seen this with cancer patients who are pretty alert till the end, and they just say, I'm not hungry, I don't want to eat, it makes me uncomfortable. So again, it's a lot of education of the caregiver that it's okay, especially in the later stages, if they're not eating. We always offer, but you don't force the issue.
Thank you, Barb. And as we're kind of coming to a close, we've got about a minute left. One thing I do want to throw in there, and this is hard to hear, and those of you who've been on our programs and in support group have heard me say this before, that person with dementia is not going to die because they stop eating. They stop eating because they are dying. Their body starts to shut down and they just know to stop eating. They don't need the fuel anymore. If it's earlier in the disease, there's some appetite stimulants that we can try that often work, but sometimes they just don't need the fuel anymore. So great program. Thank you, Becky, and thank you, Barb. This has been fantastic. Be looking for the follow-up email. We do have support groups starting at 1 o'clock for those of you who want to be part of that. And then you will get a copy of the recording of this as well. Jamie?
And yes, so we'll send out that follow-up email. Idris, did you have another thing to say?
I have one quick question. Is there any way that I can get emailed those support groups? Because I have a lot of patients that never need a lot of support.
Absolutely. We'll send you that flyer right now. And we appreciate everybody being on. We appreciate the engagement, and a special, huge, again, thank you to Barbara and Becky for your expertise on here. We'll share out the slides. We'll make sure you get a copy of the recording, and y'all have a great rest of your day.
Thank you.
Thank you.
Y'all.
Bye-bye.